For many years, autologous transplant was a mainstay in multiple myeloma. And many studies showed when you compare autologous transplant to conventional therapy, at that time it was pre-novel therapy and then novel therapy, but of course it was without the quadruplet induction, that patients that underwent autologous transplant had a better response and a better progression-free survival in 6 out of 7 studies, and in 3 studies, better overall survival. Now, of course, autologous transplant is old, it's chemotherapy, and we all want to get for a very fancy kind of therapy. And everything is immunotherapy. Revlimid is immunotherapy, immunomodulatory drugs, and we have now the monoclonal antibodies, anti-CD38 antibodies, and now the drug-conjugated antibodies, the bispecific antibodies, and we have the CAR T cells. So the question if still we need the autologous transplant, and I would say definitely yes, because transplant is the best way a more efficient way to get to measurable residual disease negativity, 10 to the minus 5 and 10 to the minus 6, and also most importantly, sustained MRD negativity. And I will show all the new studies with quadruplet induction, Cassiopeia studies with the DARA VTD, Griffin study with the DARA VRD, KRD with DARA, like Costa study, the master study, all of them show that MRD negativity post-transplant was in higher percentage and more sustained mainly more sustained, for instance, in the Forte study than after induction therapy. And so transplant is here to stay, and also with the most fancy therapy today, the CAR T cells. So we can do the CAR T cell post-transplant, but vice versa, doing transplant after CAR T cells is not logic. There are still many patients that relapse after CAR T cells. We don't have MRD sustained data after CAR T cells, and of course, at the end of the day, we will combine CAR T cells and autologous transplant. And the last is practical issue, that when the ida-cel and clita-cel are approved, only minority of the patient can get these drugs because it's so complicated, so few slots, production is much less than the demand. So from the practical issue, we can offer transplant to actually all myeloma patients that are eligible for transplant, while CAR T-cell is still for minority of patients, and at the end of the day, we combine all.